This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Eduardo Bruera, Department Chair in the Department of Palliative Care and Rehabilitation Medicine in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston. Hello, Dr. Bruera.
Hi.
I know that you're giving an educational session here called Supportive, Palliative, and End-of-Life Care: Similarities, Differences, and Integration. And I just knew I had to talk to you. Mm-hmm. So if you would please share with us the basis of your educational session and really the points that we want to drive home for both physicians, for patients, their family members, to get this dialogue going.
Thank you. It's great to be here. Thank you for inviting me. And I guess the emphasis of our session is on the person. And basically, Maimonides, about 900 years ago, said that he knew a good physician was one that would not so much emphasize the disease as the person carrying the disease. And basically, when I trained as an oncologist, I trained to treat the disease. And in fact, our cancer centers are not called cancer patient centers, they're called cancer centers. And we study cancer medicine. And that's why patients come to cancer centers. They want their cancer to be gone, and they want to have their cancer treated. But the person is enormously important because the suffering is associated with the person carrying that cancer. And basically what palliative care does is it addresses the person that carries the cancer. And so it's an incredibly useful integration between the existing services that deal with treating the cancer and with palliative and supportive care that deals with the person with that cancer. So we have made great progress in the last 15 or 20 years in integrating all the personhood, all the suffering, the physical suffering, the emotional suffering, the spiritual suffering of the patient and the family, and being able to treat it, address it, assess it. Now we've learned that while we made great progress, the progress was mostly focused on the final part of the disease. And there's a lot of distress much earlier in the trajectory of our disease when we get diagnosed with cancer. And so we're now working on getting to see our patients and families much earlier in the outpatient area and work together in an integrated fashion with the primary oncologist to make them feel better during the disease process.
In your educational session, the supportive palliative and end-of-life care, when we speak of similarities, differences, and integration, could you please speak to some of those similarities, differences, and areas of integration?
Yes, I think the main differences that we can see are chronological. End-of-life care, hospice care was the very beginning of this process. And that was very close to people who were really going to die of their disease. It became clear in the process of end-of-life caring that a lot of the suffering had happened much earlier. Palliative care emerged to get that type of personhood care and to make the dignity, this alleviation of suffering, the accompaniment, the being there and the accompanying patients earlier when they were in the acute care hospital and then in the outpatient area. And basically supportive care is an even earlier stage that allows to accompany patients through the vast majority of their trajectory of their disease. One of the problems with supporting patients is that they have multiple problems. And what palliative care specialists can do is in one visit deal with physical, emotional, spiritual, family issues, avoiding visiting 7 different other disciplines. When the patients are tired, they're having somebody drive them back and forth to the hospital, and they're having multiple problems. You need to providing as much as possible a one-stop shop where they can see someone who can deal with multiple worries, and perhaps a small percentage of them might need a more specialized referral.
I'm very grateful that you took time out to spend with us today in the group room. Dr. Eduardo Bruera, Department Chair, Department of Palliative Care and Rehabilitation Medicine in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston. Thank you so very much.
Thank you. Thank you for having me here.